Good morning, everyone. Thanks a lot, AOS, for giving me the opportunity. We have seen a lot of, real extreme cases. Now, everybody would be, liking to comment on this. So, a 50 female with a road traffic accident. Pointer, can you pointer? Okay. So, now the first question is what we are dealing with. So, it's probably an olecranon with comminution, an elbow dislocation, and radial head chip fracture. And a chip fracture of the radial head. Obviously, we'll ask for a CT scan. So, this is what the CT scan showed. There was the dislocation of the elbow. There is a lot of comminution of the coronoid fracture, coronoid piece, and there was the small piece of coronoid lying anteriorly also. And there is a fracture of the radial head as well. So, it's a terrible triad. Peroperatively, as soon as we opened from a posterior approach, a radial head was popping out of the fracture. We tried much to pull the anterior fragment of the coronoid by going through the fracture to the anteromedial compartment, but couldn't get it. So, the plan B was to go higher and medial to get the fragment back, but was a bit skeptical for that. So, decided let us fix the coronoid and olecranon first, check the joint stability, and then decide further. We had all the plates ready on table, but as the fracture of the olecranon was so high, we were not getting enough screws proximally. So, we put an interfract to hold the coronoid and then did dual tension band wiring, the figure of 8 tension band wiring and the encirclage wire as well. So, this is what we got on table. It was quite stable. We had fixed the olecranon coronoid with an interfract, and still that fragment was left as it is. So, we left it thinking that if it will come in the way of flexion or make the elbow unstable, we will go for the second stage with more preparation. And this is the 1 year follow-up. The fracture has united absolutely well, and still that fragment is lying there, and the patient is quite happy with almost full range of motion, full extension, full flexion. Another case, adult male with vehicular accident. There is a grossly comminuted proximal ulna and radius. This is what the CT scan showed. It's a proximal ulna with olecranon fracture, comminuted fracture of the coronoid, and with a separate medial wall, and comminuted fracture of the radial head as well. So, this was the per-op picture. The part of the radial head again was popping in the fracture. That only the part of the radial head which was popping in the fracture was removed. The broken medial wall and the coronoid was fixed provisionally with the K wires. An interfragmentary screw was fixed holding the coronoid and the medial wall. That was a transverse screw. The olecranon LCP was put with long screws holding the coronoid. A small LCP was added to support the broken medial wall, and the lateral compartment with radial head fracture was almost left as remnants. So, this was the 4 months follow-up. And fracture has healed well, and we didn't touch the radial head, and patient has almost full extension and almost full flexion. So, each fracture fragment does not need to be fixed. Optimum stability should be the goal for fixation without further disturbing the soft tissues. The desire for good postoperative X-ray should not end up with dissatisfied patient with much restricted ROM or infection. Radial head, if attempted in this kind of multiple fractures, and if only excised, that may add instability. Radial head prosthesis may lead to overstuffing in cases of comminuted proximal both bone fractures. So, sometimes better may prove enemy of God, and I remember Prakash Amin Sahib who always tell ke Bhagwan ni chutli na khanoi. Thank you.